Hello, this is Dr. Russel Sher. I'm on the board of the North Carolina Integrative Medical Society, and we're putting on a most fantastic conference in Asheville called the Southeast Regional Integrative Medical Conference. We have a lineup of the most amazing speakers in functional medicine who are coming to this conference, and I would like to invite you to consider coming. We are interviewing a few of the speakers prior to the event, and today I have invited Dr. Sam Yanuck to be interviewed on his topic of autoimmune disease. Dr. Yanuck practices in Chapel Hill, North Carolina. He has a functional medicine practice. He is also CEO of Cogence Immunology, which is an online functional immunology course, which is fantastic. I'm actually doing it myself. He is adjunct assistant professor on the program of integrative medicine at the medical school at UNC at Chapel Hill. He is well renowned in the field of dealing with difficult autoimmune cases. So welcome, Dr. Yanuck.
Dr. Sher, it's a pleasure to be here.
So I know you've got some very interesting information to give us at the conference. And I've been through a lot of difficult cases, treating a lot of difficult cases with autoimmune conditions. And I've been practicing functional medicine for about 25 years. And I've seen various iterations of how to address functional medicine. You know, back in the 1990s, we used to talk about protocols and having specific protocols, which was more like a cookie cutter approach. I've seen the emergence of being more specific around working with the leaky gut, with genomic issues, with the microbiome, working with the oxidative stress effects. Obviously, gluten plays a large role in it. But Dr. Yanuck, what would you say when addressing someone who comes to you with autoimmune disease? What are the most important factors to focus on?
Sure. I think that what I would propose to do is to reframe the question, because everyone wants to think about, maybe everyone's not a fair word, but the tendency is to think about a laundry list of potential addressable items and to think about, okay, what is the order of operation in which those items should be addressed? And what I would propose is that that's probably not the right way to think about it. Probably it's more productive to say, in the past 20 years or so, and most especially since about 2007, an enormous number of breakthroughs have occurred in understanding the underlying immunology, so that instead of saying, I'm going to do this, 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 and this, it's more useful and gets you more of a robust effect sooner to say instead, okay, I'm going to go through a history, I'm going to do lab work, I'm going to look at everything that has and hasn't worked in this patient before, and that together is going to give me a map of the underlying immunology of this patient. And once I've drawn that map, that tells me where I need to intervene. So instead of saying, this is more important than this in some imagined hierarchy, it's going to work out better to say, what are the underlying immunological mechanisms and what factors are feeding into them problematically? So that puts you in the driver's seat much, much more effectively and puts you in a position to choose clinical tools that match the core targets more appropriately. And that's different in different people, though there are certain themes that play throughout.
When you're thinking about this map, how do you assess these factors? Do you use specific lab work or these clinical findings that you're looking at?
Mm-hmm. It's a combination of history and labs primarily, and to an extent physical exam.
You know, I've found when people have come to me with a range of, I've treated a range of autoimmune conditions, and sometimes I put them on a program and they respond really well, really quickly. Other times it doesn't seem to budge, and I can't seem to get to turn it around. So why is it so difficult with some of these, especially extremely inflamed conditions, to get them to turn around?
Well, there are, as you can imagine, a lot of different possibilities for why that might be the case. There are some common things that get missed oftentimes. One of which is that excuse me, the tendency is to always want to squash down the inflammatory process as the first most primary thing to do. So you always want to tend to give curcumin and resveratrol and vitamin D and vitamin A and fish oil. And there's this imagined sense of, what could go wrong, right? But there are a couple of problems with that, one of which is that if a patient's T-cell polarization patterning is of a particular type, then what can happen is that instead of promoting regulatory T-cell response, which is the sought-after effect to quiet down autoimmunity, what can happen is that you can skew off into a different T-cell polarization pattern because the attempt to promote tolerance essentially is not going to succeed if there are problems with T-cell polarization patterning that prevent that move from working. And those patients will either not get better or they will get worse. The other component of that is that if your attempt to promote tolerance succeeds, but the patient is carrying an underlying pathogen burden, viral pathogens, molds, Lyme, whatever it is, if they have an underlying pathogen burden and your core move is to promote tolerance, you'll get an expansion of the pathogen burden along with the tolerance. The expanded pathogen burden will sooner or later, and oftentimes sooner, reactivate and keep pushing the inflammatory process along so that you'll ultimately fail to create the resolution of the inflammatory process, and the inflammatory process will continue to trigger autoimmune flare activation. And what's worse is that if you have expansion of viral components that used to sit there in the background doing nothing, if you promote tolerance, diminish surveillance, those background viruses expand. It's known in the research that increased viral burdens can be associated with the instigation of new autoimmunity. So if you have a patient with one autoimmune disease, but you allow expansion of a viral burden that's associated with a different autoimmune disease, that person may now begin to express phenotypically that new autoimmune process that they were not expressing before. Now the person's got two autoimmune processes instead of one. And that's obviously not, not advantageous to the case.
Thank you. That certainly explains a lot in terms of the particular approach of just going through a laundry list or following a particular protocol, that we really need to treat the person individually according to their makeup and their genetics and their what's going on, and assess what's going on and treat them from there, to not just promote the tolerance, the immune tolerance, which is really treating the symptoms, isn't it?
Well, it's a kind of a general thing to do. And again, it's not wrong. It's just that in particular kinds of cases, it may not be what you want to do first. You may need to address their T-cell polarization dysfunction first, so that when you do take your shot at inhibiting inflammation and downregulating autoimmune activation, that can work the way you have it in mind. So it's the right thing to do, but it may not be the right first thing to do.
That makes a lot of sense. So when someone comes to you with an acutely inflamed condition, you're not going to immediately just put them on resveratrol and turmeric and fish oils, which will dampen the system, but you're fully assessing the problem and addressing, for instance, if there is a stealth infection, to address that.
That's right. If there's a stealth infection, if there's a T-cell polarization imbalance, and you want to spend at least the first week or two addressing that T-cell polarization imbalance, and then you may want to just go right into curcumin, resveratrol, D, A, fish oil, things like that, once you've made it okay to do that.
That makes a lot of sense. And what other mistakes are clinicians making in working with autoimmune diseases?
Well, I think that's the primary one. Um, the 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 other one may sometimes be this, that you may be on the right track, but not using high enough doses of the things you're using. So, if you're trying to move T cell polarization, you may have chosen appropriate candidate tools for doing so, but you may not be pushing hard enough. Or if you're trying to dampen the biology of inflammasomes, which are structures inside cells that when they assemble start pouring out enormous amounts of inflammatory cytokines. You may be targeting inflammasomes with appropriate substances, but you may have underestimated the extent to which you need to push. So sometimes what I'll see is, in fact, I saw someone yesterday like this, a clinician referred the patient to me for consultation, and the patient was taking very appropriate things, but two of the key ones, one of them, the dose needed to be increased by a factor of 4, so 4 times as much. Another needed to be increased by twice as much in order to have a shot at creating an adequate biological effect. So it's not just choosing the right things, it's choosing the right amount of the right things.
So what I'm hearing that you're going to be giving some really useful clinical information, and what we're interested in is providing the kind of information that clinicians can go back on Monday and apply right away.
Yes.
In essence,
that's right.
What are you going to provide for clinicians in terms of tools to look at autoimmune disease that they can take home and apply right away?
Yeah. Well, I think the goal is to put clinicians in a position where they understand how to make the map, understand how to use the map in making the decisions, and understand what the right tools are for addressing the things you will most commonly see in the various kinds of patterns of autoimmune expression that you run into in clinical practice. So that when they show up on Monday, their capacity to recognize what's going on and address it systematically is very, very much intact. And the key thing too is this: you don't want to approach autoimmune process as a set of declarations about what you know is going to work, because that's destined to fail, right? These are complex cases, and the patient has seen a dozen doctors. And so what you don't want to do is say right off the bat, oh, I know I can help you, because doctors 1 through 11 also said that. And you don't want to say, well, I'm going to give you this, this, and this that I know will work, because the chances are they've taken those things already, right? So you don't want to tell them things they've heard before that were part of a process that they already failed with, right? So much better is to say, okay, we're going to make a map of the underlying biology. We're going to target some particular targets there. If you think of that map as like the map of a small town in northern Italy, right? All these roads converging in different ways, and inevitably a set of traffic circles, right? Where the action is in those points of convergence, those traffic circles. If you can disentangle those traffic circles, then you don't need to deal with 50 factors. You can deal with 3 or 4. And that's much simpler for the patient, and it's much more efficacious. But the key thing is, when you start the process, you're going to give the patient an instruction. Then you're going to say, come back in a month. When the patient lands in a month, you will learn more about the case by seeing how they did. And you will go, what I do is I go cycle by cycle on about a 1-month cycle. And what I tell the patient is, as many of these cycles as possible will be therapeutic, and every single cycle will be diagnostic. So that we're going to learn iteratively more and more deeply what's happening with the patient by understanding their responses to the various things that we implement with them. So that is, first of all, much closer to the truth, right? Because the truth is not that you know on the first day exactly what's going to work. That's just not true, so you might as well not say that, right? And you'll also engender much more confidence on the part of the patient by describing it that way, because the patient's mind is, the patient is usually smart, they're reading a lot of stuff. So to describe it as a collaborative, ongoing discovery process really recruits their participation in a much more effective way. So what I'll teach you guys on that weekend is how to understand the immunology to put you in a position to get that kind of work done with your patients.
That's very exciting. And thank you very much for your time today. Again, I invite everyone to register for this seminar. You can go to ncims.com, and the conference will be on June 21st and 22nd. I look forward to seeing you there.
Good. I'm looking forward to it as well. Thank you, Dr. Sher.